For years, luteal phase deficiency, or LPD, has been a really common diagnosis when we talk about fertility. But here's the big question. Is it a real standalone condition, or is it maybe just a sign of something else going on? Well, in this explainer, we're going to break down the latest scientific opinion from the American Society for Reproductive Medicine to see what the evidence actually says. All right, so here's what we're going to cover. First, we'll get on the same page about what the luteal phase even is. Then, we'll jump into the controversies around luteal phase deficiency, how it's diagnosed and treated. And finally, we'll wrap up with what the ASRM recommends and their big conclusions. Okay, so first things first. Before we can even talk about a deficiency, we have to understand what a normal, healthy luteal phase looks like. This is the super important second half of the menstrual cycle, and honestly, its job is absolutely critical. So the luteal phase kicks off right after ovulation, and it usually hangs around for about 2 weeks. Its one and only mission, to get the uterus ready for a potential pregnancy. It's all about making sure that uterine lining is perfectly prepped for an embryo to implant and thrive. It's this really elegant four-step process. Right after ovulation, what's left of the ovarian follicle turns into something called the corpus luteum. Think of it as a temporary little factory that starts pumping out the hormone progesterone. That progesterone then signals the uterine lining, the endometrium, to get thick and welcoming. If an embryo shows up, the corpus luteum keeps on working. If not, it fades away, hormone levels drop, and the cycle starts all over again. All right, now let's dive into the main event, this really controversial diagnosis called luteal phase deficiency, or LPD. I mean, the idea's been around since 1949, but believe it or not, it's still a huge point of debate today. On the surface, the classic definition seems pretty simple, right? It's just a luteal phase that lasts 10 days or less. The whole theory behind it was that this short window just doesn't give the uterus enough time or enough hormonal support to actually sustain a pregnancy. And here is the absolute bombshell from the ASRM, right up front. Even though LPD has been diagnosed for decades, there is no solid scientific proof that it, all by itself, is a direct cause of infertility or pregnancy loss. I mean, that is a huge shift in thinking. So you're probably wondering, why is it so controversial? Well, it all starts with this massive problem in how it's diagnosed. It's like you're trying to measure a target that is constantly moving. It's just incredibly tricky. So let's tackle the first big myth, the one almost everyone asks about. Can't you just do a simple blood test for progesterone to figure this out? It seems so logical, right? Well, here's the catch with that blood test. Your body releases progesterone in these little pulses. And get this, your levels can swing wildly. I mean, up to 8 times higher or lower in just 90 minutes. So a single blood draw is just one snapshot in time, and it could be totally misleading. Okay, so if a blood test is out, what about what used to be called the gold standard? Taking a tiny sample of the uterine lining itself to see if it's developing on schedule. And this is where the old way of thinking really starts to crumble. Big studies found that biopsy results were all over the place. Even for the same person, the result could be different from one cycle to the next. In fact, about a quarter of biopsies from women who are known to be fertile still looked out of phase. The test just couldn't tell the difference between a fertile person and an infertile one. And that brings us to the ASRM's final word on it. They are crystal clear here. They state that the endometrial biopsy is not a valid clinical tool for diagnosing luteal phase deficiency, period. So if we can't even reliably diagnose it, that raises a pretty massive question about treating it, doesn't it? Let's follow the evidence and see what it says about the treatments that have been tried. This is the logical next question, right? If you can't be sure someone has it, does it make sense to just treat them anyway? Just in case it helps? This is what doctors call an empiric treatment. And a few different strategies have been studied over the years. The one you hear about most is progesterone supplementation. But other things have been tried too, like using HCG injections to boost the corpus luteum, or even using drugs like clomiphene to try and create a stronger ovulation. So here it is, the bottom line. After all of those studies, the data just isn't there. For people who are having natural cycles, not undergoing IVF or something similar, no treatment aimed at fixing LPD has ever been proven to actually improve their chances of getting pregnant. And this brings us to a major pivot, a real aha moment in how we should be thinking about all this. If LPD isn't the root problem and treating it doesn't seem to help, then where should we be looking? The ASRM is basically telling us to reframe the entire conversation. We shouldn't look at an abnormal luteal phase as the disease itself. Instead, we should see it as a symptom, like a big flashing signpost that's pointing to a different underlying problem that we need to investigate. So, what's the real focus then? Well, the ASRM points to a whole list of known conditions. Things like thyroid problems, high prolactin levels, even things like significant stress or PCOS. The new approach is, let's find and treat these root causes, because if you do that, the luteal phase will very often fix itself. All right, let's bring it all home and wrap this up with the official takeaways from the American Society for Reproductive Medicine, which gives us some much-needed clarity on this whole topic.
First off, let's be clear, the ASRM isn't saying that short luteal phases don't happen. They absolutely do. Seeing a luteal phase that's 10 days or shorter is a real clinical observation. The debate isn't about if it happens, but about what it means.
So here are the key takeaways. Number 1, the priority should always be to look for and treat any underlying medical conditions first. 2, those old endometrial biopsies for dating, not recommended anymore. 3, there's just no solid proof that LPD, on its own, causes infertility. And finally, we still need more good research to really understand the full picture.
And that leaves us with one final really important question. While the old idea of LPD as this standalone disease seems to be on its way out, the conversation isn't completely over. Could it be that, with better science down the road, we might come up with a new, more precise definition of LPD that helps us find a very specific group of people who really could benefit from support? For now, though, the message is clear. Focus on the root cause and your overall health, not on an outdated and unreliable label.